Good evening. Welcome, everyone. Thank you for joining us tonight. My name is Jim Evans. I'm the chief of the Brain Tumor Division here at Jefferson. On behalf of our Department of Neurological Surgery, Brain Tumor Division, and the Jefferson Multidisciplinary Brain Tumor Center, I'd just like to welcome everybody to the second of 4 weekly webinars during Brain Tumor Awareness Month. Brain Tumor Awareness Month is intended to recognize the vast number of patients afflicted with brain tumors, their families and friends who support them throughout this journey, and the medical personnel that dedicate their lives to this fight against brain tumors. Tonight's webinar is entitled Introduction to Radiation Treatment for Brain Tumors and Symptom Management. It's presented by Dr. Wenyin, who is a professor of radiation oncology here at Jefferson. Dr. Shi has a vast experience and expertise in the focused radiation treatment of brain tumors. He not only has a very busy and productive clinical practice, but he's involved with clinical research and clinical trials to improve the field and has been a real leader in this area. So it's my pleasure to introduce Dr. Wenyin Shi. Wenyin, take it away. Thank you.
Thank you very much for the introduction. Welcome everyone for the second webinar for this month of the Brain Tumor Month. And let me start sharing my screen. All right, there we go. So today we would like to start with some introduction of the radiation treatment for brain tumors and also have some discussion for the symptom management. We already received quite a few questions, so thank you very much for people who already submit their question for today's webinar. But for the people who are just joining, please feel free to enter the question, so we will try to cover it at the end of this seminar. Here's some quick disclosure. So I want to just start with some introduction about the landscape of brain tumor, brain cancer, and some of the epidemiology data. So as you're aware, brain cancer is actually quite rare. Of all the cancer diagnosed annually in the United States, the primary brain cancer only accounts for about 1.3%. So it is relatively low incidence. Unfortunately, the outcome is less favorable than many of the solid tumor cancers of the body. As you can see, despite only about 1.3% of the incidence, this overall death is at about 3%, indicating this is type of cancer tend to have aggressive behavior and unfavorable outcome. There you go. When we look at the primary brain tumor, fortunately, we're seeing that about 3/4 of the brain tumor are fortunately benign. So the most common one will be meningioma. Then pituitary gland and nerve sheath tumor will be less common following the meningioma. But about 1/4 of them will be the primary brain tumor. Out of the 1/4 of the primary brain cancer or brain tumor, that is about 50% of them will be the most aggressive form, which is the glioblastoma. And in the general distribution, we also see some interesting trend. As you can see, majority of the brain tumor or brain cancer tend to occur more frequently in male populations. But some type of brain tumor tend to be more common, particularly some of the benign tumor, including the meningioma, being the most significant one, tend to occur more frequently in female. Despite the low incidence of the primary brain tumor or brain cancer, the metastatic cancer of the brain actually is quite prevalent. So for patients with advanced cancer of the body, about 20 to 40 of them will ultimately develop metastasis to the brain in their disease course. And the overall incidence is actually over a 250,000 annually in US. So the incidence is more than 10 times more common than a primary brain cancer. And we also anticipate to see an increased incidence of the brain metastasis patient population. There are a couple of reasons, including we have an aging population, and we are doing better with the management of the primary cancer. So the survival of the patient with lung cancer, breast cancer, and other types of solid cancer keep increasing as a result, and more patients may unfortunately develop brain metastasis towards the end of the disease course. And the novel therapy, like immunotherapy and target therapy, are most significant change on the landscape that really increase the outcome of patient. Besides that, we also tend to observe and survey our patient more active. We are getting high resolution MRI scan and for patient who has no symptom for screening, and we are able to pick up small brain metastasis and able to intervene early and ultimately to better outcome. But radiation treatment play an essential role in the management of brain metastasis. When patient with brain cancer or brain metastasis and their presenting symptom can highly variable, depends on the location of the tumor and regarding the size as well as the growth rate of the cancer. And the common symptom, as you can imagine, could be headaches, feeling tired or weak, and could lead to some mental status changes, seizure. If the tumor is compressing certain part of the brain or certain part of the nerve in the brain, they can develop some neurological deficit or cranial nerve deficit. But it really heavily depends on this location, the size, and the growth rate. And as you can imagine, for a fast-growing cancer, they tend to have more severe symptoms. For slow-growing benign tumor like meningioma or schwannoma, patient may have no symptom for years, even decades before they become symptomatic. And as you can see, that's different type of tumor. It can really have very different presentation. Here are two examples. For example, the first one on your left side is the acoustic neuroma. And the presenting symptom for those patients often is hearing loss. And unilateral hearing loss and can prompt evaluation. And the imaging diagnosis is actually very, very specific. And on the other hand, if we have another benign tumor or the meningioma, but involving the cavernous sinus, in that area, there are many cranial nerve travel in this anatomic location. The tumor in that particular location can lead to neurological deficit, such as facial pain, facial numbness, or double vision. So when we have someone present with symptom we suspect for brain tumor, there are some key important evaluation techniques. Imaging is very, very important in diagnosis and the follow-up in patient with brain tumors. The most common one is often start with a CAT scan. The CAT scan can serve multiple purposes. One is for patient who developmental status changes or neurological deficit, a quick CAT scan without contrast can quickly rule out a stroke. And some tumor actually is quite visible on the CAT scan, and they can prompt further evaluation. And here are some examples. For example, on this panel, you can see there's some edema, and in this, you can see a mass. In the lower panel, you can see there's some calcification. Certain tumor tend to have calcification. Meningioma will be one of them, but other type of tumor can have calcification as well. And also, some benign tumor can cause bone reaction. And this is an example of meningioma-associated bone reaction. As you can see, compared to the other side, this side of the bone is very thickened, and the border is no longer smooth. And this is a classic bone reaction associated with a benign tumor like meningioma. But the most important imaging modality when we are evaluating or diagnosing a patient with brain tumor is MRI scan. As you can see, compared to the previous slides, you see the CAT scan, the MRI scan give you so much more detailed information. It gives you very detailed information regarding the brain structure and also very detailed information about tumor characteristics, because MRI scan of the brain and will have many, many different sequences. Each sequence will show different tissue in different imaging characteristics. And with all those information put together, it really helps us to narrow down the differential diagnosis. Some tumor, as mentioned earlier, can be diagnosed very, very reliably with an imaging study, but some tumor may require a biopsy, a tissue confirmation. For example, here, this is a very classic looking acute neuroma, and a diagnosis by imaging usually is sufficient for the majority of patients. And for the middle panel, you can see the tumor attached to the dura and most consists with a meningioma. But other type of tumor in the other parenchyma of the brain often require tissue diagnosis for us to know exactly what type of tumor, what is the pathological grade, and or any subtype or molecular makeup. And that leads to our pathology diagnosis. As mentioned, many of the primary brain cancer require patient diagnosis because now we are moving towards a molecular diagnosis area. So when we try to work out and diagnose a patient with brain cancer, just looking at a tissue under the microscope with a standard H&E staining or histology is not sufficient because we already learned that many of the tumors, they may have the look-alike under the scope, but the biological behavior can be dramatically different if they have different molecular makeup. For a primary brain cancer, for example, like a glioma, some of the key molecular mutation, including the IDH and the TER mutation. And a patient who may have a low-grade appearing glioma, but if they have a TER mutation on IDH wild type, their biological behavior could be as bad as GBM. So this is currently the 2021 WHO classification. How can we diagnose and classify a primary brain cancer? And you can see it's pretty complicated. It has multiple layers of diagnosis. It's called integrated diagnosis. Basically, we are looking at the histology features. We are looking at the grade, and we are looking at the molecular features of those tumors to reach a final diagnosis. And the molecular mutation and molecular alteration is actually key override many of the histological findings. So here is the current our neuropathologist workflow when they have a glioma patient who underwent surgery. This is how complex the algorithm for them to reach a diagnosis. Definitely not planning to cover the detail of that at all, but just give you an example and have some idea that now we actually doing very comprehensive evaluation of the primary brain cancer, try to narrow down and the molecular features help to tailor the treatment and help the prognosis prediction. So let's switch the gear, focusing on the main topic of tonight, which is the role of radiation treatment of brain tumor. One of the most important take-home message is radiation treatment plays an essential role in the management of brain tumor, including both benign and malignant brain tumor. And this is a variety list of the benign and malignant brain tumor, but radiation treatment plays a key role in managing all of them. And many of the patient tumor involved in the brain has mass effect and require local control. And many of the systematic drugs commonly used for extracranial cancers often does not get into the brain adequately well or does not have adequate efficacy against brain tumors. So the local treatment, including surgery and radiation treatment, is very important in the management of brain tumor and brain cancers. So what is radiation treatment? Radiation treatment use high energy rays, and the rays we talk about could be X-ray, which is most common form, but also now with the modern techniques, also some is available for proton beam, which may have some advantage in certain situations. And those beams are used to target the cancer cells and lead to the cell kill. And like surgery, it is a localized treatment. So radiation treatment focus precisely onto the tumor and try to spare the normal brain tissue to make sure we can eradicate the cancer cells or treat the brain tumor, but protect the normal brain tissue to mitigate the side effect and toxicity of the treatment. And almost all the patients with brain cancer will require radiation treatment as part of their treatment strategy. And the history of radiation oncology is actually relatively young. As you can see, the field starts just a little bit over 100 years ago. In 1895, Wenyin first discovered X-ray, and soon afterwards, the radioisotope was discovered. And in the 1950s, the deep reaching high energy clinical treatment equipment really become available to clinical use, which is the linear accelerator, which is the workhorse of the current radiation treatment for brain tumor. And as you can see, over the years, we have new technology. Most notably is the proton and the radiosurgery, which developed in the 1960s. With advanced imaging techniques and other advanced computer science and the technology, we are able to continue to optimize our radiation treatment delivery. The ultimate result is we are actually able to deliver radiation treatment more precise, which is able to treat the tumor more effectively and minimize the normal tissue dose that can lead to less side effects or complications. So what is radiation exactly? So when we talk about the radiation for clinical use, either X-ray or proton, is really what we call ionization radiation treatment. Basically, those radiation particles of the photons carry very strong energy. When they interact with the cells of the body, they're able to eject electron from the atom of the cells, and then that can lead to DNA damage. And X-ray is the most common form of ionization radiation treatment used in clinic. As you can see, when we talk about electromagnetic radiation, the spectrum is very, very wide, including when we talk about the gamma ray, X-ray, but in our day-to-day, like light, microwave, or radio, or part of them. But the key difference is how much energy is captured by, is carried by each particle of the ray, which is called a photon. And as mentioned earlier, X-ray, what we use most commonly in clinic, carry a very, very high energy. But in the other hand, light or microwave or radio wave, they carry very, very low energy. For example, if patient was exposed to total body irradiation, means when they have radiation treatment to the entire body, a dose of 4 gray is the unit of radiation treatment, and can lead to 50% of the patient death if they were not getting medical management. But the energy in that 4 gray of radiation treatment is only about 67 calories. So what that means roughly 1 sip of lukewarm coffee. That's how much energy you're actually take, will have by and getting a small sip of water and coffee. So indicating that it's not a total energy that matters. It's really the photon energy, how much energy carried by each photon is really matters. And the radiation works is by damage DNA of the cells. So I often tell patients, radiation almost like a scissors is going to chop up the DNA of the tumor cells. When the tumor cells' DNA are damaged, so they cannot proliferate, the cancer cells tend to proliferate very fast, so the DNA damage can lead to fast cell death. Benign tumors, they grow slowly, so DNA damage will due to very slow death of the cells. So, cancer after radiation treatment tend to melt away. Like a brain metastasis, successful treatment can lead to shrinkage or disappearing of the brain metastasis. On the other hand, benign tumor, the radiation treatment will lead to stabilization or very gradual shrinkage of the tumor over time. And we often do radiation treatment once a day, Monday through Friday, for weeks. And the reason is try to separate the normal tissue and a cancer response and really try to achieve best cancer kills with minimum normal tissue damage. And how can we select patient for radiation treatment? The most important one is, we actually, particularly in Jefferson, we have a multidisciplinary clinic to evaluate patient as a group, along with different colleagues from other specialties, including surgery, as well as neuro-oncology or medical oncology. And so there's a tumor board discussion. We discuss all the cases and make a decision as a consensus recommendation. And we evaluate patient together with different specialties and try to formulate a plan along with the patient and family. And some patients may need radiation treatments, but the only need radiation treatment will be sufficient. Most of benign tumor can be treated very successfully with radiation treatment alone. On the other hand, many of the primary brain cancer require a combination of radiation treatment and chemotherapy after surgery for maximum benefits. The radiation treatment process starts with the consultation, and then the patient will come in for the special preparation for radiation treatment. Our team will do behind-the-scene work, and then when the patient will ready to start treatment, and after treatment, they will return for routine follow-up. During the consultation, as mentioned earlier, we will meet with the patient and family to discuss treatment options and recommendations. There are different treatment regimens of radiation treatment may be involved, and we will make certain recommendations based on the patient situation. Then we'll discuss the side effect and toxicity of radiation treatment. When the patient is determined need radiation treatment, we will arrange patient return for the CT simulation. The CT simulation is basically a preparation process. So during that time, patient will come and they will lie on a CT table, and we will make some immobilization device. And most of the brain tumor is basically a thermoplastic mesh. So the plastic mesh will keep the PET in a very, very stable position. The whole process takes about 15-20 minutes. There's no preparation needed, no sharps, no needle, and there's no marking on the skin. And patient can leave right after the fitting is done. So after fitting is done, then we will do what we call radiation treatment planning. That involving multiple people. Usually we will review the imaging with our neurosurgery colleagues, and we will define where the cancer is or the tumor is. Then also we will segment all the normal tissue, which we will set certain goals to protect them, make sure the radiation treatment will not lead to excessive toxicity or risk. And when those goals are set forward, our team of physics and dosimetrists, who are the specialists who do the radiation treatment calculation, will do what we do called radiation treatment planning. Basically, they're using a computer software system to design radiation treatment beams from different angles and different dosage from different entry points to achieve the maximum coverage of the tumor, but the minimum dose to normal brain tissue. That process can take several hours to a week, depends on the complexity of that. And after radiation treatment plan is done, the radiation oncologist will review, and everything meet our criteria, and a field deemed to be a high quality plan will be approved for treatment. But before the patient actually return for treatment, there will be pretty extensive physics checks, and also including QA process to make sure that the plan meet all the quality and safety endpoint before we actually schedule patient for treatment. And the radiation treatment is an outpatient treatment. Usually it's 10 to 15 minutes on the table each day. There are two major regimens of radiation treatment. One is what we call the standard fractional radiation treatment. Those are most commonly given for patients who has large benign tumors or primary brain gliomas, and or tumor very, very close to a critical structure. Then they require radiation treatment every day, Mondays through Friday, for multiple weeks, often 5 to 6 weeks. And during that treatment course, the radiation oncologist, we will evaluate the patient on a weekly basis and address patient side effect toxicity along the way. There's another type of radiation treatment called radiosurgery, and many people refer to by the vendor's name, such as Gamma Knife or CyberKnife. And this is a type of treatment that delivers very precise treatment over a very short period of time, often 1 to 5 treatments. So that's more efficient, but those are limited to certain indications, which I will discuss further. And the radiation treatment has a very, very long track record for successfully managing the brain tumor. Use glioblastoma, for example, and the data or the studies done in the late 1970s, simply giving patients a whole brain radiation treatment after surgery actually doubles their survival compared to surgery alone or surgery with some of the systemic therapy agent. And this highlight the importance of a radiation treatment as a local treatment for patients with brain cancer. For many of the benign tumor, we not only able to achieve tumor control and often aim to achieve organ preservation or function preservation. And this is patient, with acoustic neuroma, as mentioned earlier, often can lead to hearing loss. And surgery, even though is one of the treatment options for acoustic neuroma, it can lead to complete loss of hearing in majority of patients and often put patients at a risk of a facial nerve injury or facial paralysis. But radiation treatment, on the other hand, is able to achieve excellent tumor control and with almost no risk of facial nerve injury, and also can have favorable hearing outcome, particular patient with a good hearing to begin with. So as mentioned, over the years, the radiation technology really evolved. What we are doing right now is we are able to use advanced technology to really achieve very, very precise radiation delivery. Currently, for our brain tumor center, all the brain tumor treatment is delivered using what we call a stereotactic radiation treatment. Basically, it's a word indicating that we're using 3D localization to deliver precise treatments for the patient. So almost it's like a wood carving process. And at this point, we are at the stage that we are able to fine tune the radiation treatment and able to pinpoint. The radiation treatment equipment is so precise, we are able to aim to the sub-millimeter accuracy for the target. And so this is essential for the brain tumor treatment due to the critical geographic location and all the critical structure nearby. And this is one of the example of a tumor in the cellular area called a craniopharyngioma. This is a benign tumor, but it's very close to optic chiasm, optic nerve, and a brainstem. And the radiation treatment plan, as indicated here, is able to achieve very precise treatment to the tumor and minimize the dose to the brainstem, as well as the optic chiasm and optic nerve. And as mentioned earlier, besides the standard fractionation treatment, one of the really important and unique treatment for brain tumor is a technique we call radiosurgery. Radiosurgery is actually developed by a neurosurgeon, Dr. Lascal. And the concept is really try to mimic what a stereotactic neurosurgery biopsy with radiation. So as you can see on this graph on the left panel, the surgeon sometimes will use stereotactic devices, try to reach a certain part of the brain to get a tissue. And the external coordinate is so precise, we can pinpoint exact location inside the brain. And this is the surgical approach. But in certain location, it is not safe for surgery intervention. But if we imagine to replace the biopsy needle with X-ray and pinpoint X-ray that can precisely aim to that particular location, and that become radiosurgery. So radiosurgery basically is giving many of the pinpoint radiation beam to aim to the lesion in the brain with external coordinates with a very precise localization. That allow us to deliver high dose radiation treatment to the part of the target in the brain, but also try to minimize the normal tissue side effects by minimizing radiation dose to the other part of the brain. There are many equipments that able to deliver this type of treatment, including Gamma Knife, CyberKnife, the Tomo, the most recent equipment called a ZAP, but they are very much as different vendor equipment doing the same job, and it's really not about the key is not about equipment. It really just is about the know-how and team expertise to make sure they are able to achieve the best treatment, take advantage of the technical advantage of each equipment. The radiosurgery definitely has a lot of advantage that become really well received when it's first developed. After it's first developed, first of all, compared to neurosurgery approach, it certainly avoid invasive procedure and avoid all the risk of anesthesia, bleeding, and hospital stay, minimize the morbidities and the recovery time. As you can imagine, for the same type of treatment, the surgery can takes several days in hospital and post-op recovery, potential rehab, or even weeks of recovery. For the radiosurgery, it's very much a one-time outpatient procedure. So very, very convenient for the patient and family members. And it also has advantage to treat the area that is not safe for the surgery. For example, lesion in the middle of the brainstem, lesion close to major artery, lesions that is in the adequate area of the brain. Surgery can lead to neurological deficits or significant morbidity and mortality, but radiation treatment is able to reach all the areas surgery is not safe to reach. And we're also able to treat patients who are not fit, that do not have the medical stability to undergo surgery on a seizure. Unlike surgery, each lesion require different access pathway. We are able to treat many of the lesions in the brain concurrently or sequentially and without any issues. And the radiation treatment also, radiosurgery is also being favored compared to other type of conventional radiation treatment. For example, for patients with brain metastasis, the conventional radiation treatment involving radiation treatment to the entire brain. It does have some clinical benefit, but certainly carry a lot of toxicity and side effects. Radiosurgery become preferred treatment for the patient with brain metastasis now because we are able to achieve very favorable local control, but also minimize the radiation dose to normal brain. As a result, we are seeing less neurological deficit, including memory function or neurocognitive functions deficit from the whole brain radiation treatment. But as mentioned earlier, if we consider radiation treatment, radiosurgery for patient, we have to be more careful. In a simple way, is almost like we are compressing a radiation treatment delivery course over 5 to 6 weeks into 1 to 5 sessions. So we deliver much stronger radiation treatment over a much short period of time. So we have to be very cautious to avoid any potential injury or complication. Some of the criteria we need to make sure we are following. One is we are able to treat radiosurgery for lesions are small. If we're treating a large lesion, there will be too much normal brain tissue receiving radiation treatment, which can lead to side effect toxicity. Usually, we'll carefully evaluate the size of the lesion. If the lesion is less than 3 centimeters or so, often we are able to treat over 1 session. And if it's a little bit more than 3 to 4 centimeters, but it's less than 6 centimeters or so, we may be able to treat safely with 2 to 5 section, but it also depends where are the nearby structure. Is it safe to keep the structure in the safe range? And so there are certain area radiosurgery may not be a safe or preferred treatment of those patients. As mentioned earlier, critical structure in a nearby location is one of the major consideration. If the tumor, for example, meningioma involving the optic nerve or compressing optic nerve, and giving radiation treatment very, very quickly over 1 to 5 treatment will lead to a high risk of optic nerve injury. So those patients may not be suitable for radiosurgery and may require treatment over weeks. That will be daily treatment over about 5 to 6 weeks. And brainstem and as well as other critical structure have the similar consideration. So it has to be evaluated by experienced neurosurgeons and radiation oncologists to make sure the treatment is done correctly and safely and of high quality. But when we treating using the technology well and able to take advantage of the technology able to offer, we are actually doing something that's very, very impressive. And is, for example, as mentioned earlier, the tumor close to optic nerve or optic chiasm, we need to be very, very cautious about not causing injury to those structures. But with advanced technology, we are able to achieve a very safe delivery as long as tumor is only about 2 millimeter to 3 millimeter away from optic nerve, and we are still able to treat the tumor adequately without causing, high risk of optic nerve injury. And that certainly provides a lot of convenience compared to coming back and forth every day for 6 weeks in a row. So this is the radiosurgery workflow. It's more or less the same as external beam radiation treatment. Patient will need to be fitted for immobilization, and they will do the contouring, treatment planning, and delivery. Historically, radiosurgery is delivered with a invasive immobilization, basically in a head frame, which anchored to the skull with pins. And many of the gamma knife practice still using the same localization methods. It certainly allow very stable immobilization of the head, but the process is inconvenient and uncomfortable for the patient. And in Jefferson, we are able to transition all the patient to a frameless treatment, means all the patient will have radiation treatment with the mask, which is much more comfortable and more convenient. And we have extensive data and experience here, besides all the industry data, to indicating that the mask treatment has the same accuracy and precision as the frame-based treatment. At Jefferson, we also really very keen on introducing newer and innovating technology is further improve the efficacy as well as if the experience a patient received radiosurgery. One of the example is radiation treatment for patient who has multiple brain metastasis. As mentioned earlier, radiation treatment technology right now allow us to target many lesions in the brain and even concurrently. And this particular software is one of the first we actually introduced in the country and in the region to use that allow us to concurrently treating multiple lesions in the brain, and which dramatically reduce treatment time and maintain the efficacy and the safety profile of the treatment. So rather than people go to a gamma knife center, if they have 10 brain metastasis, they need to have treatment one by one. It can take hours. And we are able to treat those patients over 15 to 20 minutes, and all the lesions will be treated with the same dose as the gamma knife center. And the efficiency and the comfort level for the patient will be dramatically improved. And the software is very streamlined, and we also allow us to potentially perform treatment in the same day by patient preference. And here is one of the example of patient who has 22 brain metastasis, which was treated over one session. As you can see, this radiation treatment plan, or the color lines and the color wash indicating different dosage of radiation treatment. Obviously, we want to keep the tumor at a high dose, which indicating by the purple color, but normal brain tissue, as you can see, has very, very low dose. And this is the treatment results. 2 months after treatment, you can see dramatically shrinkage of the lesion. Some almost completely went away, so indicating a very, very successful treatment. Beyond the brain tumor, we also have the technology allow us to treat some benign lesion, which is non-cancerous. One of them will be the AVN, which is arteriovenous malformation. This software and the technology also allow us to deliver the radiosurgery for those patients in a non-invasive way, and we have fully transitioned our treatment to the frameless system and have very successful results based on this new technology. Regarding the toxicity and the side effect of radiation treatment, certainly we need to be mindful, and but the exact risk or potential risk and side effects really highly variable, depends on the tumor type and location of the tumor, size of the tumor, and radiation dose, radiation fractionation schedule. So it's very difficult to give one size fits all kind of answer for all the patient. But in general, some of the mild non-specific side effects could occur in most of the patients receiving radiation treatment that involves fatigue, occasional headache, a little bit nausea, and it depends on the location and the type of tumor you treat. Majority of the patient may experience some hair loss, and they may experience some level of the neurocognitive function difference, including maybe have some trouble concentrating. And the most concerning toxicity for radiation treatment, particularly when we're giving high-dose radiation treatment like radiosurgery, will be potential injury to the nearby normal brain structure, the healthy brain, which can lead to radionecrosis. And so we really need to have experienced team that's, have experience managing brain tumor, and also have a technical teams able to plan and calculate a radiation treatment plan in the way that achieve excellent tumor control, but also have a very safe low dose to the radiation to normal brain tissue, and that will ensure the minimum toxicity associated with treatment. And as I mentioned earlier, the overall the toxicity and risk profile are highly variable, depends on the tumor type and radiation regimen dose, as well as whether the patient getting chemo or not chemo. So many factors that's taken consideration, and really rely on a careful discussion with the radiation oncologist before the treatment. And the most common side effects, which indicating like large bubbles, means that happen pretty common. Majority patient will have some level of that, but the severity and the duration of this irritation tend to be low and short. On the other hand, but some of the later term risk or injury that can occur in much fewer patients, but those toxicity could potentially be severe and require more significant intervention and management. So overall, as just as a quick wrap up, as you can see, radiation treatment really plays an essential role in the management of brain tumor. Majority of brain cancer patients receive radiation treatment, and many of the benign brain tumor patients, if they are not able to have complete surgical removal or have recurrence after surgery or have too much at risk of surgery, are very well suited for radiation treatment. But treating brain tumor with radiation is a very dedicated situation. We have to carefully balance the normal tissue tolerance and the tumor control, and really rely on an experienced team and advanced technology. And the special new technology such as radiosurgery certainly is a very attractive treatment modality for certain type of tumor and conditions that can really have the high efficacy, low morbidity, and provide a lot of convenience. All right, so I'll wrap up here. And I already have several questions received, so I can try to cover those first. But if any other question, please submit in the chat. So these are some of the questions we received before the webinar. The first one is, what are the long-term effects of radiation treatment and how long? So that is a very good question. And as mentioned, most of the patients will experience some short-term irritation, but the long-term toxicity mainly in two forms. One is the radiation impact on the normal brain tissue can lead to some delayed reaction. For example, brain radionecrosis with long-term toxicity from radiation treatment. So those means some of the normal brain tissue get damaged from radiation treatment, but that usually does not occur right after radiation treatment, but happen months or years down the road. Of the most common time frame is 1 to 1.5 years after radiosurgery. And those can even occur several years after radiation treatment and require a different level of management depending on the severity of the radiant necrosis. And some of the risk of a nerve injury can also occur many months or years after radiation exposure. For example, if patient get radiation treatment to a tumor or cancer very close to the optic nerve, and it can lead to some nerve injury or damage happen afterwards, and that can potentially occur a year or more afterwards. And some of the deficit can potentially be like lifelong. But most of the long-term toxicity usually occur within the first 2 to 3 years after radiation treatment is over. The second question about the memory issue after having radiation treatment for an inoperable meningioma. First of all, I think the memory issue overall is relatively low for patients with meningioma because meningioma are not in the parenchyma of the brain, but also on the surface of the lining of the brain. So often we are able to deliver radiation treatment to the meningioma or minimize radiation treatment dose to the parenchyma of the brain, particularly the memory center like a hippocampus or limbic system. And also the potential memory impact depends on the size and the location of the meningioma. But majority of the meningioma radiation treatment has minimum memory issues after the radiation exposure. The next question asks about pain near the radiation site, still persists after several years after treatment. So pain is actually a very uncommon side effect of the radiation treatment because radiation treatment often does not lead to either the peripheral nerve damage or sort of cranial nerve damage that can lead to pain symptoms. Often the pain associated radiation area is a combination of radiation and a prior surgery, and the radiation treatment can potentially lead to some wound healing issues or delayed reaction of the surgical area that may manifest with some pain symptom. Again, those are very uncommon and usually will resolve after radiation treatment is over. The next question is whether radiation treatment is painful. As mentioned earlier, radiation is X-ray, so very much like a CAT scan, chest X-ray. You don't see or feel anything during the treatment, and you actually will not even know the radiation treatment is on and off. So it's not painful, and you will not even notice radiation treatment is being delivered. What is the success level in radiation treatment for brain tumor? So that's also heavily depends on the type of brain tumor. So for majority of brain tumor, like benign brain tumor, acoustic neuroma, pituitary tumors, meningiomas, radiation treatment has a very, very high success rate. And radiation treatment is able to damage the tumor, so prevent the tumor getting larger. For benign tumor, they do not necessarily shrink, or they shrink very, very slowly, but radiation treatment will stop the growth of the tumor, and that is highly, highly successful. The success rate usually in the range of 95% or so, even higher. For cancerous tumor, the success rate is more variable. Radiosurgery, when we're giving a high-dose radiation treatment for brain metastasis, we are able to achieve a local control success rate in the 85–90% range. But those patients are at the risk of developing new brain metastasis. So the outcome ultimately depends on the type of brain tumor. Benign tumor usually have a very, very favorable local control, but cancerous lesion tend to have variable outcome. How much growth in a brain tumor qualifies for radiation, and how do you determine? So I think this question is more probably relevant to a benign tumor which is being watched, and if we start to see the tumor getting larger, and then we need to make some decision regarding when or whether to proceed with treatment. So that's also variable by the patient's tumor type and the tumor location, as well as neurological deficit associated with the tumor. In general, for benign tumor, when we are seeing imaging evidence of tumor progression, means tumor getting bigger on a serial MRI scan, that is a sufficient indication for us to consider intervention, and could potentially be surgery or radiation treatment. And you can imagine benign tumor usually have an indolent growth pattern, so there's no urgency or no emergency. But if we have very clear evidence the tumor is getting bigger over time, then further waiting does not really bring any benefit, potentially lead to some more toxicity or potential neurological deficit. So if we see tumor growth on a serial MRI scan, that usually is adequate indication for radiation treatment or other intervention for benign tumor. What is expected timeline for recovery of radiation treatment? That is also depends on the type of radiation treatment and the tumor type, whether the patient getting chemo or not chemo. Patient have a small meningioma, they may not have much side effect at all, so the recovery time is minimum. But patient may have like a GBM, they receive a chemotherapy and radiation treatment to a large part of the brain, the fatigue or weakness and other symptoms can lingering for a longer period of time. What is the success rate after radiation treatment for the eradication of meningioma? So benign tumor, they do not get eradicated per se by radiation treatment. The radiation treatment goal for benign tumor is not to make them disappear, but to damage the tumor so they cannot grow. So as mentioned earlier, radiation works by damage DNA of the tumor cells. So after radiation treatment, the DNA of the meningioma will be damaged. As a result, they cannot proliferate, so it will not get larger. And that is actually highly successful, as mentioned, about 95%. But the meningioma does not disappear. It will get a little bit smaller over the years, but it will never ever disappear completely. Are there any expected side effects from the radiation treatment? I think we did briefly mention it depends on the site, tumor type, radiation dose, tumor volume, whether getting chemo or no chemo. So it's not really one size fits all answer. And a careful and detailed discussion with radiation oncologists should be carried out before the initiation of radiation treatment. The next question is I'd like to find out more about acute, delayed, and delayed effects of radiation. What do they look like? What tissue are involved? What are treatments for injury and damage look like? And also like to find out more about radiosensitivity of tissue in the past of the photon radiation, like nerve nuclear. It's also a very broad question. And as mentioned, tumor type, location, dose, and the tumor size is very, very important to predict the potential side effect and the outcome. Regarding the normal tissue tolerance, fortunately, we actually have a lot of knowledge regarding how much normal brain tissue, the normal nerve, brainstem, spinal cord, or certain part of the brain can handle successfully without running to toxicity. Whether the patient have one-time treatment, 5-time treatment, or 30 treatment over 6 weeks. And all those are carefully taken consideration in the radiation treatment planning process. So we make sure all those normal tissue tolerance are very well observed, and that will help mitigate the toxicity and the risk of complications. All right, so I think there are a couple more questions just being entered during the webinar. After craniotomy surgery, the MRI scan showed residual meningioma grade 1 enhancing that narrows adjacent mid 1/3 of superior sagittal sinus in a measure about 1.5 by 0.8 centimeter in the maximum dimension. SBRT5 treatment is recommended. Any comments? Again, as mentioned earlier, we are carefully selecting patients to have, radiosurgery or fractional radiosurgery. Another name of the fractional radiosurgery is SBRT treatment, basically giving a focused radiation treatment over 1 to 5 times. The tumor at 1.5 centimeter by 0.8 centimeter clearly meeting the criteria. As mentioned earlier, usually the rule of thumb is less than 3 centimeter lesion So it's clearly meeting the criteria. The big vessel is quite resistant to radiation treatment, so the radiation does not necessarily lead to the big vessel injury, but in the parasagittal area, that sensitive area is more sensitive to radiation-induced side effects like inflammation or brain necrosis. So even though the patient potentially be eligible for single fraction radial surgery, 5-fraction SBRT regimen is actually a very good treatment regimen recommendation. Mentioned molecular genetic features of brain cancer. Any study was done in molecular feature of meningioma. And the short answer is yes. So current classification for meningioma by the WHO classification actually has certain molecular features that will grade the tumor into grade 3 or grade 2. So those molecular features are being tested and incorporated in clinical practice. If a patient have a meningioma resection at a Jefferson, they will all have molecular testing to look at for high-risk genes. So those studies, there are studies being done, but it's actually already incorporated into our daily practice. And Monica asked, can you talk a little bit about seizure coming either from the tumor itself or particularly myoclonic seizure? So radiation treatments sometimes can lower the seizure threshold because the radiation treatment can lead to brain edema or swelling. So when there's swelling of the brain tissue, it potentially allows the seizure to occur more likely, but this is not necessarily radiation-induced injury of the nerve that lead to seizure. More likely is lower the seizure threshold. So often the management including steroids to reduce inflammation, changes of the brain, and anti-seizure medication. As a matter of fact, radiation treatment has been shown to help control the seizure, particularly patient with glioma. So there are previous studies looking at low-grade glioma, which the main presenting symptom is seizure. So for the patient who receive radiation treatment, the seizure control is more favorable compared to patients who do not have radiation treatment. So from the pathoetiology point of view, radiation treatment can actually help with seizure, but the radiation-induced side effect like inflammation in the brain tissue and swelling itself can potentially lower the seizure threshold for patients who had the seizure problem to begin with to more likely to have some breakthrough seizure. The next question is, do you review MRI and PET scan image to determine the radiation treatment? It depends on the tumor type. Most of the time, MRI scan is sufficient for the radiation treatment planning for many of the brain cancer or brain tumor. Some PET scan are being incorporated, help us to better differentiate or tailor the treatment. One example will be the dotatate PET for meningioma, something we try to do routinely for the patient right now. Last but not least question, does radiation treatment Jefferson provide a proton treatment for GBM? If not, why? Unfortunately, that is not available yet. It is certainly a large-scale decision for Jefferson Enterprise regarding the resources, availability, and available access. So proton, fortunately, is readily available in this region, and Jefferson is actively evaluating the option, but currently we do not have that option yet. Okay, I think that's all the questions we have. I don't know if everyone has any other questions.
Dr. Shi, I'd like to thank you for presenting tonight, sharing with us your expertise. I know I learn a great deal from you every time I hear you speak, and I'm sure everyone else benefited as well, so thank you. I'd also like to just thank all the participants for joining us tonight. We enjoy doing these webinars, and we hope you're enjoying it as well and benefiting from it. I'd like to invite everyone to join us next week as well. We'll have an update on neuro-oncology clinical trials, and that'll be led by Drs. Glass, Dr. Alnahas, and Dr. Martinez. So thank you again for joining. Hope everyone has a great night, and we look forward to seeing you next week.
Thank you everyone for attending. Good night.